Bismillah Rahman Rahim. Assalamu alaikum. Welcome into the fifth episode of our workshop on management of diabetes mellitus in the month of Ramadan. In the last episode, we discussed management of type 1 diabetic patients, those who are on insulin. We discussed the adolescents as well as the adult patients who are using insulin for the control of their diabetes. As mentioned in the last episode, today we are going to discuss management of type 2 diabetes patients who are using oral drugs or who are using insulin or who are on the combination of orals and insulin. How to go about it, what changes we need to make in their drugs, in the oral drugs and in their insulin. So be with me. Today, we are diving deep into the management of type 2 diabetic patients in the holy month of Ramadan. It's the fifth episode of our workshop. And as mentioned in the last episodes, we are going to discuss type 2 diabetes mellitus in the month of Ramadan. Ramadan fasting among people with type 2 diabetes can present many challenges. The key concerns relate to uncontrolled blood glucose levels that can lead to hyperglycemia and or hypoglycemia. Especially those patients whose blood sugar is not controlled, it really poses a great challenge. Appropriate and effective blood glucose monitoring and medical management of type 2 diabetes is crucial to ensure safety during Ramadan. We need to adjust their medication, and this is very, very important. The type of medication the patient is taking for the management of their diabetes influences the potential risks that fasting during Ramadan may lead to, and therefore requires careful attention when formulating the treatment plan. This is very important. When before Ramadan, you make the decisions and you give them a trial that during Ramadan, what their medication adjustments will be needed. The primary concerns relating to these medications are their risk towards hypoglycemia. There are a couple of drugs which can lead to hypoglycemia. There are a couple of drugs which can lead to dehydration. Particular care must be taken when individuals are on multiple anti-diabetic therapies, and the healthcare professionals' advice need to account for this when making dose modifications during the pre-Ramadan assessment. So this is very, very important that you assess all drugs and you see which drugs can cause hypoglycemia, which drugs dose can be reduced, and which drug timings can be changed from morning to the evening. Anti-diabetic drugs such as Metformin, acarbose, TZDs, GLP-1 receptor agonists, and DPP-4 inhibitors work in a glucose-dependent manner and generally have a low risk of hypoglycemia. These drugs generally don't require any dose modifications during Ramadan. So this is a common principle or a general principle. Short-acting insulins, secretagogues, are also safe for use during Ramadan. Therefore, it is recommended that the normal 3-meal dosing is redistributed to accommodate the eating patterns, that is the iftar and suhoor during Ramadan. Modern sulfonylureas like glimepiride, gliclazide, and glycoside modified release. They carry a slightly higher risk of hypoglycemia and therefore should be included in the pre-Ramadan assessment. Specific attention needs to be given to these. Sodium glucose cotransport 2, that is SGL2 inhibitors. What about these? For stabilization, SGL2 inhibitors should be initiated at least 2 weeks to 1 month prior to Ramadan. SGLT2 inhibitors are recommended to be administered at the time of evening meal, iftar. However, if the indication for SGLT2 inhibitors initiation is cardiovascular or renal protection, then the pre-Ramadan initiation should be conducted with a lower dose. So these are the few specific points which you need to consider when you prescribe SGLT2 inhibitors. Increasing fluid intake during the non-fasting hours of Ramadan is recommended when a patient is using these drugs because they cause dehydration. SGLT2 inhibitors do not require treatment modifications during Ramadan. The dose remains the same. However, if an individual is on multiple medications, a review of the doses should be made to avoid the risk of hypoglycemia. This is important. When they are solely on these, then they don't need dose modifications. But when they are on multiple dosages, then their dose modification is required. When a patient is on insulin treatment for the control of their type 2 diabetes, insulin used during fasting carries a risk of hypoglycemia, especially when more complex insulin regimes are used. And so extra care and caution must be taken when developing Ramadan medication regimes. So this is specific caution about those patients who are using insulin. Remember, administration of insulin via subcutaneous, intramuscular, or even intravenous routes do not cause a breaking of the Ramadan fast. So remember this. There is misbeliefs in patients, and when they will get the insulin, it will break the fast. There is a fatwa about this, that these do not break the fast. Let's discuss these drugs in more detail, starting from the oral anti-diabetics. First, take the metformin. If the patient is on once daily dose, then no dose modification is required, except that if the patient is taking the drugs in the morning, this metformin OD dose should be taken after iftar during Ramadan. So the morning dose is changed to the evening dose. If a patient is on twice daily dose, then again no dose modifications, and take at iftar or suhoor, and they can be using the same dosages, provided if they use the same strength. Suppose if a patient is using 500 milligram metformin tablet in the morning and 250 milligram metformin tablets in the evening in the non-fasting days, or suppose 1 gram in the morning and 500 in the evening, and the sugar is controlled, then you switch those. The lower dose should be in the suhoor and the higher dose should be in the iftar. If the patient is on 3 timely dosage, daily dose, for example, taking 500 milligram 3 times a day, then the morning dose taken before suhoor, and they combine the afternoon dose with the iftar dose. So what you do, that the morning dose should be the same, and the lunch dose or the afternoon dose and the evening dose, you combine them, and you should be taking this in the iftar time. Prolonged release metformin drugs, no dose modifications, and if the patient is taking in the morning, it should be taken in the iftar. Coming to the second drug, the icarbose, again, no dose modification is required for this drug except the timings. That if the patient was taking in the morning, it should be taking in the evening time. Then the TZDs, that is the pioglitazone, again, no dose modification, but dose can be taken with iftar or sohar, but preferably I tell them to take after the iftar. Then the GLP-1 receptor agonist, semaglutide, and the others, no dose modification after appropriate dose titration have been achieved. These are the weekly dosages. Then the DPP-4 inhibitors, vildagliptin, sitagliptin, no dose modifications. One thing is that they should be used after iftar, not then at the suhoor, because they do cause urination and dehydration may be a problem. For the SGL2 inhibitors, dapagliflozin, empagliflozin. If the patient is using the DAPA and empagliflozin, and in the morning, they should be changed to the iftar time because they do cause dehydration. And the vildagliptin can be taken in the morning or in the iftar time. I personally, if the patient is on OD dose, I tell them to take after the iftar because the chances of hypoglycemia, so-called hypoglycemia, is minimized here. And the problem with these two is that they cause urination, so I prefer them to be taken in the iftar time. This is all important. And of course, in the non-fasting hour, the patient should be using, should maintaining the good hydration. Coming to the sulfonylureas, the glimepiride, gliclazide, and gliclazide modified release. If they are on once daily dose, reduced dose in well-controlled individuals, and they should take this at the iftar time. If the twice daily dose, the suhoor dose should be reduced in a well-controlled individuals. And if the patient is on the insulin, then there are specific recommendation for these. If the patient is on long or intermediate acting basal insulin, then the like NPH, detamar, glargine, they once daily. So reduce the dose by 15 to 30%, and it should be taken after the iftar. And those who are on the NPH, detamar or glargine, who has twice daily, they take usual morning dose at iftar and receive the evening dose by 50% and take that at the suhoor. So you change the timings. And in the short-acting insulin, normal dose at iftar, omit the lunch time dose and reduce the suhoor dose by 25 to 50%. So these are the type 2 diabetic patients who are using the insulin. Similarly, changes to premixed insulin dosing required in Ramadan for type 2 diabetes. Once daily dosing, take normal dose at iftar time. You change from morning to the iftar. Twice daily dosing, take normal dose at iftar and reduce the suhoor dose by 20 to 50%, the morning dose. And three timely dosing, those who are using three injections, omit afternoon dose, adjust iftar and suhoor, and then carry out dose titration every 3 days, depending upon how the patient responds. And this the changes which are needed for when there is a fasting, pre-iftar, pre-suhoor blood glucose. When it's less than 70 milligram or there are symptoms, then the basal insulin should be reduced by 4 units, and short-acting insulin in the pre-iftar and in the post-suhoor, it should be reduced by the 4 units. The basal insulin and the short-acting. If the sugar is less than 90, then reduce the dose by 2 units or each. When it is 90 to 126, no change required. When the patient is using the insulins and you check the blood sugar, and if the fasting blood sugar is found to be 120, more than 126, though you increase each by 2 units. And it is more than 200, though you increase each by 4 units. This is the simple calculations. You can find all these in available charts. So in case of the type 2 diabetic patients who are on insulin, their regular monitoring is important, and you decide accordingly after 3 to 4 doses whether the patient needs to decrease the dose or increase the dose. What about special populations? The pregnant women with diabetes and elderly individuals with diabetes. These are the two groups, a special population who need special care when they want to fast during Ramadan. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome into the second last episode of our series on diabetes mellitus and Ramadan. In the first episode, we discussed that why should we talk about management of diabetes in Ramadan fasting. Then in the second episode, we discussed the impact of Ramadan on physiology of a human body, its hormones, and its metabolism. In the third episode, we discussed how to stratify diabetic patients into high risk, moderate risk, and low risk regarding Ramadan fasting. High risk patients are those who should not fast. Moderate risk patients are those who can fast but under strict control and monitoring. And low risk patients are those who can fast without any fear. Then we discussed in the next episode the management of type 1 diabetes mellitus, how to manage adolescents and adults with type 1 diabetes mellitus. Then in the last episodes, we discussed management of type 2 diabetic patients. As said in the last episodes, today we shall discuss special populations. That what about pregnant ladies who are diabetic and if they want to have the Ramadan fast? And second, elderly people with diabetes, and if they want to fast during Ramadan, so what about them? And in tomorrow last episodes, we shall discuss the complications in diabetic patients because of Ramadan fasting, the possible complications, what complications they can have. So today we are going to discuss special populations. The sixth episode of our workshop on Ramadan and diabetes. And today we shall discuss the management of special populations of diabetic patients in Ramadan fasting. And these will include pregnant women with diabetes and elderly individuals with diabetes. So first take the pregnant women with diabetes. We know in Islam, all pregnant women have the right not to fast regardless of whether they have diabetes or not. So this choice has been given to all pregnant women. For those that do fast, expert support and guidance is needed in order to improve safety for both the mother and fetus. The potential risks of fasting among pregnant women with gestational diabetes mellitus, pre-existing type 1 diabetes mellitus, or type 2 diabetes mellitus is high. So a pregnant woman can have three types of diabetes. It may be gestational diabetes, who has appeared or diagnosed during pregnancy, and it is because of the pregnancy, or it may be a pre-existing diabetes, it may be type 1 or type 2. It is recommended that pregnant women with diabetes not to fast until further research is available to support fasting. This is the medical point of view. As with all individuals with diabetes, there should be a pre-Ramadan assessment alongside individualized Ramadan-focused education of pregnant women with diabetes. There needs to be an increase in the rate of self-monitoring of blood glucose throughout the day, including before iftar, after meals, during fasting, and anytime there are feeling of being unwell. If uh, such women want to fast during Ramadan. Pregnant women that are fasting during Ramadan will need to follow the Ramadan nutrition plan, and the healthcare worker should provide this plan to them, as with all other individuals with diabetes, but also make further changes. They may need further changes, the high caloric diets, because now they are pregnant and their nutritional requirements, they are increased. Caffeine, sugar, and salt should be limited, and the eating of fibrous foods should be encouraged. There needs to be a greater effort made to stay hydrated, and pregnant women should aim to drink 2 to 3 liters of water a day. That is between the iftar and the suhoor time. Many pregnant women will be treated with insulin to manage their conditions, but currently research on the best dosing regime is scarce. The IDF-DR guidelines have recommended insulin dose and blood glucose monitoring regime modifications to be aligned with that mentioned above, that is in our previous vlogs, for those with type 1 or type 2 diabetes. Now coming to the second special population, that is the elderly individuals with diabetes. Age in and of itself is not a good reason to categorize individuals as high risk for fasting during Ramadan. This is not the chronological age. This is the biological age, in fact. But rather it is the associated implications of old age that need consideration. So once again, don't be focused on the chronological age. This is the biological age. Elderly people, 65 or even 70, they may be in very good health, biological health, and even those 55 may be in a very bad shape. Elderly individuals are at higher risk of having comorbidities. We know that. These comorbidities can include dementia, recurrent falls, hip fractures, amputation, and visual impairment. These all have important implications on the safety of fasting during Ramadan. And these complications are high when it is elderly individual with diabetes. Likewise, many elderly individuals generally have a longer duration of diabetes and will also be more likely to suffer from diabetes-related complications, such as hypertension, hyperlipidemia, retinopathy, and neuropathy, among others. This graph is showing, this was the study conducted global survey by DAR, the 2020, that the green is those less than 65 years of age, and the dark blue are those who are more than 65 years of age. So when they compare, like hypertension, it was 45.29% in those less than 65 years of age, and it was around 67% of those 65 years are over. Similarly, hyperlipidemia was around 39% in less than 65 years of age, and it was found to be 48.23% in age group of 65 years or over. Similarly, retinopathy, it was around 11% in 65 years or less, as compared to 23% in 65 years or elder. Similarly, neuropathy was almost 20% in those less than 65 years, and it was around 29% in those 65 years or elder. Similarly, the nephropathy or chronic kidney disease was around 8% in those less than 65 years of age, and it was around 18% in those 65 years or older. Similarly, coronary artery disease, stroke, TIA, peripheral vascular disease was around 8% in less than 65 years of age, and it was 20% in those aged 65 years or over. Similarly was the diabetic foot problems. It was around 3% in less than 65 years and around 5% in more than 65 years of age. So higher the age, higher is the chance of complications. It is vital that pre-existing comorbidities and any history of diabetes-related complications are identified by healthcare professionals during the pre-Ramadan assessment and risk stratification process. Importantly, healthcare professionals must also consider an elderly individual's degree of independence, as this is crucial in understanding what kind of support may be needed during Ramadan, such as with feeding. This is very important, taking medications, and checking blood glucose levels. So how much support that elderly individual has got around himself or herself. The primary concern among elderly individuals is the risk of developing hypoglycemia during Ramadan. It has been found that the risk of hypoglycemia is increased among the elderly and may often present with neuroglycopenic manifestations in the form of dizziness, delirium, and confusion. These can all lead to periods of unawareness and hypoglycemia, which can be extremely dangerous. So this is another point, and you should keep that in mind. Hyperglycemia is also an important issue and has been seen to be higher among the elderly than in younger individuals with type 2 diabetes. It is recommended that the individuals with hypoglycemia unawareness or a history of unawareness do not fast. They should not fast. A key component to avoiding hypoglycemia is self-monitoring of blood glucose, and it must be conducted frequently. The 7-point guide for self-monitoring blood glucose, which I have discussed in the previous vlogs, should be used as a guide and adopted. Moreover, medication doses should also be adjusted appropriately. Any dose adjustments that are made need to be set prior to Ramadan, ideally during the pre-Ramadan assessment. Ramadan-focused education also needs to be adopted and individualized to account for these issues. The specific guidance for the elderly with type diabetes include the following. What are these? Number 1, medication and regimes. Take care of these. Number 2, self-monitoring of blood glucose. Number 3, diet. Number 4, physical activity. Number 5, social considerations and community support. And number 6, to take care of risks of complications and awareness. Regarding medications and regimes, there should have been an assessment and discussion prior to Ramadan. You should choose medications that have a lower risk towards hypoglycemia. Make dose adjustments to lower the risk of hypoglycemia. And I've discussed all these modifications in the previous vlog. Regarding self-monitoring of blood glucose, you should increase the frequency of self-monitoring blood glucose when fasting during Ramadan than before Ramadan. So elderly individual, what frequency he or she was having for self-monitoring blood glucose, increase that frequency. Consider using a continuous means of monitoring blood glucose levels if available. Regarding diet, there needs to be an emphasis on staying properly hydrated, and this is very, very important, particularly in individuals prone to diabetes-related comorbidities or complications. Must have an adequate intake of nutrients when breaking the fast. So tell them that they should have a good caloric diet. An individualized nutrition plan should be made prior to Ramadan and adhered to during the Ramadan fast. So tell them this will be your plan in the suhoor, in the aftari, and how to be sticking around this. Physical activity. Physical activity level should be curtailed, no doubt about that, but not halted during fasting hours. So this is very important. Activities should be planned ahead of time and thought of holistically, that is, in conjunction with nutrition plans and medication regimes. Then the social consideration and community support. Adequate support mechanisms should be in place to ensure that elderly individuals with diabetes wishing to fast receive support from family members, friends, carers, or community members. This should provide greater level of safety and confidence. Regarding the risk of complications and awareness, there needs to be an active effort to increase the awareness of symptoms of hypoglycemia and hyperglycemia. Symptoms and events should be documented to help with recognition. The effects of fasting in people with comorbidities such as dementia, impaired renal functions, cerebrovascular disease, and others should be seriously considered and discussed prior to conducting Ramadan fasting. What are the complications of diabetes when fasting during Ramadan? People with diabetes that have unstable macro or microvascular complications and choose to fast during Ramadan could exacerbate these complications, and therefore these individuals are classified as high risk. These complications may be macrovascular complications and chronic kidney disease, that is the microvascular complications. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome into the last episode of our workshop on management of diabetes mellitus in the holy month of Ramadan. We started from knowing that why we should discuss this topic. Then we discussed the impact of Ramadan on the physiology of a human body, especially diabetic patients. Then we discussed in the next episode that how to stratify diabetic patients into high risk, moderate risk, and low risk on the basis of their disease and their medical history for the purpose of Ramadan, whether they should fast or they should not fast, and if they fast, then under what conditions. Then we discussed the management of our insulin-dependent diabetic mellitus patients, the adolescents and the adults. Then in the next episodes, we discussed the management of type 2 diabetic patients. In the last episode, we discussed the high populations, which included diabetic ladies who are pregnant and diabetic elderly patients, that should they fast or not, and if they fast, what are the prerequisites and how to monitor them during the month of Ramadan. Today is the last episodes, and we shall discuss the impact of Ramadan on macrovascular and microvascular complications in a diabetic patient. Episode number 7. And as mentioned in the last vlog, Today we are going to discuss the complications of diabetes when fasting during Ramadan. People with diabetes that have unstable macro or microvascular complications and choose to fast during Ramadan could exacerbate these complications, and therefore these individuals are classified as high risk. And these complications can be divided into macrovascular disease and microvascular disease. The macrovascular disease, we know diabetes is frequently associated with an increased risk of cardiovascular disease and a heightened risk of stroke. Studies have shown that the practice of unsafe fasting, including a high intake of carbohydrates, low levels of activity, poor sleeping patterns, inadequate hydration, and missing doses of essential medicines could have an impact on the risk of cerebrovascular disease or stroke in people with diabetes. Fasting during Ramadan and congestive heart failure. Let's start from this. The very common macrovascular complications, the ischemic heart disease and congestive heart failure. Congestive heart failure has been investigated by several studies during Ramadan. A multi-center study conducted in the Gulf region found no difference in the proportion of patients that were hospitalized for heart failure with diabetes during Ramadan and outside of Ramadan, 52% and 48.4% respectively. So no difference was found. A retrospective review of clinical data also found that there were no differences in the number of hospitalizations when comparing the month prior to Ramadan, the period of Ramadan, and the month after Ramadan. So regarding the congestive heart failure, no difference was found between those who fast and don't fast, or those who fasted during Ramadan and as compared to their non-Ramadan months. Fasting during Ramadan and acute coronary syndrome. What the literature says about this group. Evidence suggests that there is no clear association between fasting during Ramadan and an increase in acute cardiac events. Some have also identified improvements in the number of acute coronary syndrome events. In one study, significant reduction in the number of ACS events during Ramadan when compared to times outside of Ramadan. Likewise, in another study found protective associations between a composite measure of religiosity and ACS in a cross-sectional study. However, these studies need to be replicated through randomized longitudinal studies and among individuals with diabetes. So clear-cut evidence is not there, and both sorts of studies are available. Fasting during Ramadan and stroke. This is the third macrovascular event. Diabetes is an independent risk factor for stroke. We know that. And the effect of fasting during Ramadan in people when diabetes needs to be established. This is very, very important. There have been several studies that have investigated this relationship, and the evidence is conflicting. In one study that was a cross-sectional design study, it found that people with type 2 diabetes mellitus were no more likely to be hospitalized for ischemic or hemorrhagic stroke during Ramadan than in the months before or after Ramadan. So in one study, there were no differences noted. And another study confirmed these results in longitudinal study in Egypt. Conversely, others found that the opposite, with Ramadan fasting being associated with a significantly higher risk of stroke. Like this study, in a cohort that were primarily middle-aged, and there was evidence showing that fasting was associated with a higher risk towards stroke. So we again get conflicting sorts of results from different studies. Those that insist on fasting despite having macrovascular complications must adhere to the recommendations. So looking at the data, whether they congestive heart failure, acute coronary syndrome, or stroke. So those patients that insist on fasting despite having the macrovascular complications must adhere to the recommendations. They should receive a thorough risk assessment from their diabetes specialist, cardiologist, and neurologist well in advance of Ramadan. So these are the guidelines that such patient should have a thorough risk assessment by their clinicians. Receive pre-Ramadan education. They must receive pre-Ramadan education and understand how to properly conduct safe fasting with diabetes. Such patients should obtain individualized advice based on their current health status and treatment regimes. So you need to individualize their treatment for the Ramadan if they have got the macrovascular complications. They should practice safe fasting as discussed in these guidelines wherever applicable. We have already discussed all these in details in our previous vlogs. They should make appropriate adjustments to therapies in accordance with their symptoms. The healthcare worker needs to do that. For example, diuretics, antihypertensives, anti-diabetes medications, and insulin regimes will need adjusting to give the greatest chance of achieving safe fasting during Ramadan. And make a concrete effort to stay hydrated. They should make such efforts and get an adequate amount of sleep and nutrition prior to conducting fasting. This is very, very important. Now coming to the microvascular disease, an important macrovascular complication that can arise as a result of diabetes can be chronic kidney disease. We know that. The chronic kidney disease can be categorized into different stages reflecting the severity of the disease. We know that what are different types of the chronic kidney disease stages. So fasting during Ramadan and renal functions. What literature says? Some studies have shown that fasting during Ramadan can worsen renal function. This author showed that individuals with chronic kidney disease that fasted during Ramadan would experience deterioration in renal function, particularly in those with an estimated GFR of less than 60. Bucket et al. Also showed that the higher the stages of chronic kidney disease, the worse is the renal outcomes during Ramadan. So as the GFR worsens, the risk of deleterious effects also increases. However, others have shown that fasting during Ramadan may not be associated with any less bad outcomes or even finding improvements. Burnett et al. Showed an improvement of eGFR during and after Ramadan with no significant changes to biochemical measures such as urinary electrolytes, proteins, or osmolarity. A meta-analysis conducted on the mean difference of the eGFR before and after Ramadan among several different studies showed no clear or meaningful difference between these patients. There have been several studies that have investigated the outcomes of individuals that had previously a kidney transplant and fasting during Ramadan. So, if a patient had renal transplants, what can be the effects on that? The overall outlook is that these circumstances do not make fasting unsafe. Further research in the form of longitudinal and randomized trials are still needed to support this recommendation. Currently, the risk for fasting remains high in case of unstable renal impairment, and these individuals should not fast. This is by and large an advice. This is also true of individuals with poorly controlled diabetes, where fasting could be unsafe. Those with chronic kidney disease that insist on fasting despite having microvascular complications must adhere to the recommendations. And what are those? All individuals with diabetes, both type 1 and type 2, and chronic kidney disease, or with any other renal issues, should discuss their intentions to fast during Ramadan with diabetes and renal specialists. And at least 3 months prior to Ramadan, such consultation should be done. And they should attend Ramadan-focused education. Individuals with diabetes, both type 1, type 2, and CKD of stages 3, 4, 5 are on dialysis should be considered high risk, and fasting ought to be discouraged. Those that are considered high risk and still choose to fast must be carefully monitored and have weekly reviews during Ramadan. They should have weekly reviews during Ramadan. They should make a concerted efforts to stay hydrated outside of fasting periods, that is between the iftar and the suhoor. Monitor electrolyte and creatinine levels at various points during Ramadan. It is important to ensure safe fasting is being conducted and whether it should continue or not. They should avoid foods with high potassium or phosphorus content. So, dear colleagues, the dietary guidelines for diabetic patients during Ramadan, the key principle is focus on balanced meals, avoid large carbohydrate spikes. In the iftar, that is the breaking fast time, in the suhoor, pre-dawn time, and the hydration. These are the 3 important aspects of dietary guidelines for diabetic patients during Ramadan. In the suhoor, that is the pre-dawn meal, the aim is to prevent hypoglycemia and sustain energy. So they should use the complex carbs and fiber like oats, whole wheat, and nuts, healthy protein and fats, eggs, yogurt, and avocado. They should avoid refined carbs and excess caffeine because dehydration risk is there with these. In the iftar, The aim is to prevent postprandial hyperglycemia. In this or it was to avoid the hypoglycemia. Here it is, the aim is to prevent postprandial hyperglycemia. So they should consume slow digesting carbs with low glycemic index like whole grains, legumes, adequate protein and healthy fats, which help stabilize glucose. And of course, they should avoid large portions of fried, sugary foods. Regarding dehydration, the aim is to prevent dehydration and DKA risk. So they should at least take 2 to 2.5 liter between iftar and suhoor of water. When to break the fast? This is very important. The diabetic patient should know when I will break the fast. When he or she has hypoglycemia, blood sugar level less than 70 milligram, or hyperglycemia more than 300 milligram, or symptoms of dehydration or DKA, that is excessive thirst, confusion, nausea, vomiting, abdominal pain, these are the conditions, then he or she should break the fast immediately. Another important point is the post-Ramadan follow-ups and long-term adjustments. Review glucose trends and HbA1c post-Ramadan. Adjust long-term medication plans based on fasting experience. And reinforce lifestyle modifications for sustainable metabolic control. So the key takeaways of this workshops of 7 vlogs of 7 episodes is: individualized risk assessment before fasting is very important. Medication adjustments to prevent hypo and hyperglycemia is very important. And balanced suhoor and iftar meals with hydration focus should be the aim. And frequent glucose monitoring and awareness of when to break the fast is the pivotal fact in such patients. So, dear friends, dear colleagues, dear viewers, I'm thankful to you for being with me during all these 7 episodes in which we learned how to take care of our diabetic patients in a better way, those who want to fast, or how to advise on data-based and facts-based, that if we ask someone not to fast, how we should be making that decision. It should be data-based, it should be facts-based, because this is a very important religious responsibility on a doctor, on a healthcare professional. If he or she asks someone not to fast, it should be really a disease-based decision. And for those who are allowed to fast, and if they are high risk, then again the responsibility lies on you, that you must have done the proper assessment and should advise such patients the proper way, whether they should fast or not fast. If someone can fast and he doesn't fast, on the basis of your opinion, again, there will be guna, and guna will be on him and on you as well, more on you, that patient could fast and you said don't fast. And if a patient could not fast and you allowed to fast, again the guna comes on you if something happens to that patient. So it's a very delicate, very important, very pivotal, very vital responsibility on healthcare professionals to be able to assess their patients in a way so their expert opinion is really meaningful and according to the religious points of view as well, and according to the medical point of view as well. So I'm again thankful to all of you who remained with me during the whole workshops. I hope it was my humble attempt to aid to the patients' care in our region, and your experts' opinions, your suggestions, and your thoughts will be of great value to me. Please do share your opinions, your comments in the comment section below. So I will try to get myself educated on the whole issue, further educated myself, and of course, when we shall repeat these workshops in the next year, if the life allows, then I'll incorporate those points as well. Thank you very much once again. Inshallah, see you in another episodes of workshops or a series of this vlog on some another important health issue. Till then, take care. Khuda Hafiz.